Good evening, everyone. I begin by acknowledging the traditional owners of the land on which we meet this evening and by paying my respects to their elders, both past and present. And thanks particularly to Jeremy and CIS for inviting me to make some opening remarks this evening. I won't tarry over long on these opening remarks this evening. I suspect that there'll be much richness in discussion and question and answer. But I thought I'd bounce a ball on the issue of innovation in healthcare, and then I'm happy to be taken to the particulars of the current formation of private health insurance and other such topics, perhaps in Q&A. But the first question I think you might rightly ask in the context of this topic, innovation in healthcare, is why in the world are we here? Surely, with health and medical knowledge exploding at an almost unquantifiable rate, our topic tonight could reasonably be mistaken for a misconceived effort at kicking down an open door. But no. On some dimensions, healthcare, broadly defined, is indeed rampantly creative, a lantana of invention. On other dimensions, however, it's more like a petrified desert of fossilised forms. It's this more arid set of dimensions that I'd seek to focus on this evening, and their role in hindering what I would term valuable innovation in the healthcare sector. To clarify the distinction that I'm asking you to ponder, imagine this. We summon Alexander Graham Bell from the grave, and we transport him into a modern, yet average, Australian household occupied by millennials. Anyone know those people? Yeah. In a frozen tableau, we ask him to identify the telephone. He's stumped, and then, when explained, amazed at both the technical progress and the diffusion of the technology aided by its extraordinary cost, quality, efficiency. Imagine this, on the other hand. We summon Florence Nightingale from the grave and we take her to an Australian acute hospital. After an hour's in-service, Florence is almost ready to clock on for a shift. She has identified the location of the nurse's station on the ward, orientated herself to a familiar set of patient beds, with nurses fanning in and out to check temperatures with slightly fancier thermometers, dispense medication, update charts at the foot of beds, yes, they're still there, and has in no time identified that familiar but still rankling, socially conveyed demarcation between the doctors and the nursing staff. Florence isn't just almost ready for work, she feels at home. Hyperbole to make a point aside, the resonant truth lurking between these two thought experiments remains. Healthcare has innovated its procedural clinical interventions, its curative molecules, its diagnostic capacities, its treatment possibilities, etc., etc. But its managerial and business systems have been glacial in their rate of change and innovation, or at best sporadic, non-persistent, and not transforming or transformative of the mainstream of activity in the sector. And I'm going to open the case tonight, submitting that the fossilised business systems of healthcare are now amongst the most consequential barriers to valuable innovation, and that industry structure militates against the achievement of the triple aim of healthcare's improvement movement. That triple aim, for those who are not in the sector or aware of it, is a wonderfully boiled down shared ambition globally by leading thought leaders in the area of health sector reform. And the triple aim is broadly this. 1, improved patient experience, quality and satisfaction. 2, improved population health. 3, reduced per capita cost of healthcare. Those three things together. I submit that to unleash innovation that tackles this triple aim, we need to think more broadly and clearly about healthcare as an economic system. A system of incentives that needs to be reorientated around consumer needs, which it currently is not. Arguably, in economic terms, today's healthcare system can be characterised as an arrangement of producer interests. It's captured by producers. I cannot think, it's an arrangement with any number of voices raised that all claim the consumer and the patient interest, but a notably weak voice of the consumer or patient themselves. I cannot think of a more emblematic, evocative and resonant description of this circumstance than Inge Clendenin's limpid observation in her book Tiger's Eye regarding her treatment for major liver disease. It goes something like this. I soon learned in hospital that it is the vertical people that have all the power. This arrangement of producer interest runs deep. We are talking about a 200-year-old or more process of institutionalisation, a process that has determined an imposing edifice of healthcare buttressed by powerful elements. These include information asymmetries between clinician and patient, funding arrangements for activities, not outcomes, persistent industrial practices that shape relations between clinicians, between primary care and specialisms, between clinicians and allied healthcare. Capital formation processes that strongly influence the allocation of capital to physical assets and certain types of assets at that, for example, acute hospitals. Demarcation and boundary management issues that riddle the sector. Training models that too often reflect and entrench existing boundaries, and relationships with bureaucracies that are inflected by government's many and sometimes conflicting roles, including as funder, regulator, and as itself a producer. So what's wrong with this edifice towering over the patient and the community? Hasn't it, the healthcare sector, made remarkable contributions to individual and community well-being? No doubt. But if we are to help Inge Clendenin's prone patient stand up for his or her interests to be truly determining, it will be a part of the process to recognise the producer arrangement, that the producer arrangement is frankly unsustainable. Well, why? Not least because its form is fundamentally imbued with the acute character and episodic treatment history of the healthcare sector. Meanwhile, today, the disease challenge that it was originally configured around has shifted very significantly. In parallel, technology and managerial systems have leapt ahead, leaving the healthcare sector flailing expensively, trying to deal with chronic disease, explosions in scientific knowledge and ageing populations, using increasingly outmoded industrial, technological and managerial models. Against this condition, one might suggest a number of prescriptions as to how you might foster business system innovation. Clearly, microeconomic reform approaches have much potential value to offer. In part, the sector eluded such an approach during the major reform era that we mostly experienced here, due to its inherent complexity, the splayed nature of healthcare across all levels of government and market sectors, its structural rigidities, including its connection with the rigidities of our federal system and the powerful persistence of its historical clinical configuration, and its relatively unsurveyed nature. Governments at all levels failed to generate effective, system-wide regulatory and accountability frameworks because of their incomplete and fragmented coverage, together with their essential complicity in the operation of parts of the sector. In this vein, there is much to pick up from the recent Harper Review of Competition Policy. It would be a great shame to let the relatively confined facet of this important review relating to Section 46 occlude its many other facets, including the material opportunities to challenge business models in the service economy, particularly where governments are themselves participants and complicit in industry shape, including the resistant and self-forgiving configurations of the healthcare sector. And to underscore just how resistant these configurations are, I offer you this quote to ponder. In an attempt to arrive at the truth, I've applied everywhere for information, but in scarcely an instance have I been able to obtain hospital records fit for any purpose of comparison. If they could be obtained, they would enable us to answer many questions. They would show subscribers how their money was being spent, what amount of good was really being done with it, and whether the money was or wasn't doing mischief rather than good. Now, who said this? Any thoughts? Anyone care to hazard a guess by last week, recent healthcare reform, National Health and Hospitals Reform Commission? Christine Bennett? Anyone? No? I'm a sort of... Alan Jones? I'll have to check that, Mark. Yeah. Florence Nightingale in 1863. So it's 150 years of the sector protesting against its ability to gather meaningful information on itself. Florence wasn't just lamenting the sparseness of... Florence was famously lamenting the sparseness of information in the health system, and I would argue that little and too little has changed in the intervening century and a half. And these are not laments of small consequence. The Productivity Commission has in the last 24 hours been reiterating the ready availability of savings in the healthcare system of some 20% by driving it towards levels of efficiency that it manages to achieve today in some of its parts, but which it seems unable to generalise across its sector, across the whole sector. This is extraordinary. This is not a large ask in terms of system review and renovation. If you're actually just asking the system to look at what you do well, and everywhere in the system, please do what you do well in the same fashion, and not just by the Productivity Commission, I might add, but by study after study after study, has been shown to show up potential savings of 20-some%. Now, 20%, is that a big deal? We spend about $150 billion per annum across all payers, governments, state and federal, individuals, either out of their own pockets as out of pockets or through premiums or some other such payment. About $150 billion across the whole sector currently, and that's accelerating in nominal dollar terms currently at about $10 billion per annum. $10 billion per annum is more, I think, than was allocated to real economic infrastructure in last year's federal budget. That's just the growth in healthcare. That's not the stock, that's just the flow, and that's galloping away. 20% of the sum $150 billion that is expended annually on healthcare by all payers is more than $30 billion. That is more than any likely increase and net reallocation of GST to healthcare is ever likely to achieve. We're currently talking in Australia, in recent times, about a potential 5% or so increase in the GST. Perhaps some broadening of its base, and there's some argument about exactly what it would raise, how much you might need to compensate lower income households, etc., etc. We're all familiar with those discussions. They're on foot. The net, in most of the calculus, there'll be those who say it won't raise enough. Deloitte say you might need to use 20 of the 30 billion raised to compensate lower income households. PwC was out yesterday saying we don't agree with Deloitte, you'd have to compensate more. You know, the arguments are familiar, we go round and round. The net is some $10 billion may or may not get to healthcare across the states. Each year, it's inflating at $10 billion. And it seems to me that we are truly potentially on the path of seeking to feed the beast rather than to actually reform the sector itself. And I think there's some serious questions to be considered in that particular arena. Further, that was the 20% we're talking about, that was just about relatively small attempts to improve efficiency in the system as it operates today. But real and extensive business model innovation, rather than just approved accountability and efficiency in the current system, could lead to even more considerable improvements in the value achieved by our health dollar. Rather than seek to canvass tonight the many possible reform approaches that might lead us there, and there are many, and some have been written down and ably written down by various reviews of the system and or enacted by other pluralist democracies in the industrialised world, I restrict my suggestions to a relatively narrow front. The same space that's occupied by Florence Nightingale. Measurement of the activities and performance of our healthcare systems. We might all disagree about the scope and scale of government, but many fewer of us will disagree that governments have sometimes usefully provided foundations for human ingenuity and improvement by ensuring the integrity of weights and measures. At the very least, we need to invest in public, transparent, and improving systems of measurement for healthcare and its participants. Even this limited call, I can assure you, raises howls of protest about the complex exceptionalism of healthcare by many a complicit stakeholder. To them, I offer Galileo's retort: measure what is measurable and make measurable what is not so. Thank you.